I think I have a cold today. My nose is red and it's running like crazy. Ugh. Hey guys, so this week we're going to be tackling some drugs for allergic rhinitis and the common cold, which if you know anything, man, I don't like having a cold. It's awful. The runny nose, the itchy, watery eyes, all these can be signs and symptoms of allergic rhinitis or the common cold. And in the summer, man, it can be the real pits to get a cold. But the fact of the matter is that we do have seasons of our lives where our allergies and cold symptoms are going to affect us more. So let's learn about the drugs that we can give to our patients and to ourselves that will help to keep these symptoms under control. Here we are, we have our learning outcomes all nice and outlined for us. Please follow along through the lecture series if you're wanting to help answering any of these. So let's talk a little bit about our anatomy and physiology. Okay guys, we can't really get terribly upset with our bodies whenever we have these allergic type symptoms. Because your body is basically doing what it does best. It's trying to protect you. It's like, man, there is something out here in this environment and it is crawling up your nose, and I don't think it should be getting any further than this little area right here. So we're going to make some mucus and we're going to swell some membranes and we're going to keep that stuff from going downtown, man. So your body's just doing what it's supposed to be doing. The way that your body does that is that it works with your sympathetic nervous system and your parasympathetic nervous system. So your sympathetic nervous system kind of pulls them back together versus the parasympathetic nervous system, which helps to dilate the inside of vessels in here and produces all that great mucus. In response to that, whenever the body hits, an allergen hits your body, with what we see is we see mast cells get turned on. So typically we have two different types of mast cells. We talk about histamine 1, which is kind of like on the mucosa lining of all of this. It's in your skin, but then you also have histamine 2 receptors, which are in your gut. I will tell you that it's not uncommon whenever a patient comes in with an acute allergic reaction that we treat both sets of histamine receptors in order to get the allergic reaction under control. So what we're going to be kind of concentrating on today is allergic rhinitis. This is a response from your body in regards to whatever it has come into contact with. Some years we have really, really horrible blooms, and because we have those horrible blooms, we have more allergy symptoms. The runny nose, the itchy, watery eyes, it can be really tough. Some people, it's not about the seasons, it's about the pollutants that they're exposed to, the chemicals, the tobacco, the smoke. I have a lady's house right now that I go into on a regular basis, and I know that when I come out of there that I'm going to be coughing and sneezing and I'm going to get a headache because of all the pollutants that are in that environment. All that really triggers my rhinitis. So typically we talk about two different types of rhinitis. We talk about one being seasonal, meaning that you can predict it. You're like, you know what, every year between blah and blah, I get a huge cold, or between this season and this season. Some people used to always think that with allergic rhinitis that it only happened in the spring whenever we were having the bloom, but that's not true. We get a lot of different pollinations, different things in the air, just depending upon what time of year it is. Even location can make a huge difference. There are other patients who suffer from allergic rhinitis all the time, and so because of those patients, they have to be treated all the time, and those are more of our perennial ones. Those are like our chronic sufferers. One thing I want to tell you is that, sometimes allergic rhinitis can be like an immediate, like you walk in and you're bad, or you can have like a delayed reaction to something that you were exposed to, even up to 4 to 8 hours later. I will tell you that if mom and dad suffered from allergies, you're more likely to suffer from allergies. I can say now that as I'm getting older, and especially with children in the house, I'm like, oh, that one has allergies, and that one has allergies, and I have allergies. So they most likely, they got it from me. We'll have to go to therapy later because I gave them allergies. So with allergic rhinitis, we tend to tackle this from two different treatment methods. If we can kind of predict when you're going to have allergies, one of the things that we may do is we may prescribe you a preventer. Most of these preventer medications are over-the-counter drugs, and they do a great job at helping to keep the allergies under control. I will tell you, this was not the case 20 years ago. 20 years ago, in order to get some of these medications, it was like a trip to the doctor and a trip to the pharmacist, and then it was a call the insurance company to get them to approve them. But now a lot of the preventers and the relievers are actually purchasable over the counter, and we have very little things that we actually have to prescribe for the patients now. The other thing we want our patients to do, if possible, we want them to try to figure out exactly what's their trigger. If we can figure out what the trigger is for their allergic rhinitis, and then we can avoid that, then we can avoid taking medications. But sometimes it's just really hard to figure out in our very rich allergen environments. And so because of that, what we do is we just say, hey, you're going to take this preventer, this reliever, and we're going to treat the symptoms, and we're going to move on. Our first preventer that I like to talk about is a good old-fashioned antihistamine. You just can't beat it, guys. It is a great way to treat patients with allergic rhinitis. These are called preventers. They typically work the best if we take them before the exposure. They come in two different flavors. We have histamine 1 antagonists, and those come in two different flavors. We have a first generation and we have a second generation. The first generation antihistamines can be pretty sedating. Guys, you already know this medication. This medication's name is diphenhydramine, also known as Benadryl. You can purchase it over the counter, safe for adults, safe for children. There's a few things I want you to think about though. This medication has a lot of anticholinergic side effects. So with this medicine, we're going to get a lot of dry mouth, dry eyes. It's going to dry up all those secretions, which can cause some problems on the back end of life. One of the things patients that I always think about when we talk about antihistamine medications is I get worried about my little old men who have urinary hesitancy. So they got a big prostate, or maybe they just don't pee right. You start dropping this medication on them, you're going to cause them to have like urinary retention, like they can't pee, okay? So be thinking about that before we say, oh yeah, just go get some Benadryl and take it. In the mid-2000s, early, I guess probably mid-90s, the world of allergic rhinitis sufferers rejoiced as they began to put products on the market that used to require prescriptions. Loratadine, cetirizine, phenylphexidine, these were our second generation antihistamines. The great thing about these medications is that you can take one of them and continue to function. Diphenhydramine tends to be very, very sedating for some patients. And because of that, those patients really couldn't tolerate it. There doesn't have as many anticholinergic side effects with the cetirizine and the loratadine and the phenylphexidine as with the diphenhydramine, so tend to be a little more tolerable for our patients who may have urinary issues. We also have some intranasal antihistamines. What I really love about intranasal medications for allergic rhinitis is that it puts the medicine where the problem is, versus if I put a pill in my body, it's got to go through this whole luxurious thing that I got going on here before it gets to where my problem is. So intranasal antihistamines or intranasal medications can be very useful for patients who don't need the systemic side effects of the antihistamines, don't need that to go all over. Instead, we just need it to go right here where the problem is. So very important that you kind of think about that as we're making recommendations, as you're taking orders from physicians. What kind of medical problems does this patient have? And is the medication that I'm fixing to give them going to make it worse? Paradoxical reactions. So I have a good set of friends here in town that whatever the drug is supposed to do, their family is going to do completely opposite. So when I take Benadryl, I go to bed because it makes me sleepy. That's what the drug book says should happen. I have friends that are just not normal, and when they take Benadryl, they get a paradoxical reaction. In fact, this medication is completely and totally like it just wires them. They can't sleep for days. It gives them that big of a reaction. So paradoxical reaction is whenever something happens which is opposite from what we thought was going to happen. So it can happen in small children if they've never had the medication before. I always like to tell parents, I'm like, look, this is what's supposed to happen. However, this could also happen. And so we prep them either way, especially if they've never had it before. So it's called a paradoxical reaction, and it can happen with antihistamine medications. We have other uses for antihistamines. We give antihistamines for patients who are experiencing motion sickness. You would buy this over the counter, and it would be known as diphenhydramate, also known as Dramamine. You can also give meclizine for motion sickness. For nausea, you can use diphenhydramine, you can use meclizine, and you can use promethazine. They're all considered an antihistamine. An interesting thing is that sometimes we'll give Benadryl to our Parkinson's patients whenever they have the tremors and they can't stop them. As a nurse who used to work night shift a lot, I'd come home and I'd pop a Benadryl and take me a siesta, okay? It makes me very sleepy. However, what I found is that, I was taking 25, and the 25 worked for a while, and then I was taking 50 milligrams. And then the 50 wasn't working, and then I took 75 milligrams at a time. So you can go up on the dosage of it. However, I will tell you that eventually you will develop tolerance to that medication. A lot of the over-the-counter nighttime sleep aids, if you read the chemical that's on them, all it is diphenhydramine. It's nothing but plain Benadryl. So I always try to educate my patients about what's in their medicine cabinet, because I've literally been to people's medicine cabinets and opened them up, and they had Z-Coil sitting right beside the Benadryl. I'm like, why did you buy both? And they didn't realize that they were actually one and the same medication. The other thing we'll use Benadryl for is for like urticaria and hives. Give that, and helps to take away some of the itchy stuff going on. Another way that we can treat our patients or prevent our patients from developing allergic rhinitis is with intranasal corticosteroids. So we want them in the system 1 to 3 weeks before they start having the allergic rhinitis type symptoms. Some people can predict it, some people aren't that savvy, but we want to try to get these started on the patients. Again, it's putting the medication right where it needs to be. If I was to do a corticosteroid, for instance, prednisone, and they take that by the pill, that goes all the way through this gorgeous body and causes a whole bunch of systemic effects, when really and truly I only needed the medicine right here in my nose. Anytime you put anything up the nose, there's always a risk of nasal bleeding. I will tell you that there's always a risk of burning, the burning sensation in the nose. These medications work incredibly fabulous in order to help to decrease inflammation, decrease the swelling in the nose, and there is some mild vasoconstriction here, but not a lot. Again, our prototype for this one is known as fluticasone, and it's known as Flonase. That's the other name for it. It's an over-the-counter product. I will tell all my patients whenever they talk about fluticasone or Flonase, if I make a recommendation, I'm like, do not spend the $27 on Flonase. Buy the fluticasone. It's sitting right next there to it. Same drug, okay? The other thing I want to point out, and I don't think I mentioned this previously, is that the end of a drug will always kind of tell you a little secret about itself. It'll kind of tell you what classification it's related to. So here with fluticasone, you'll see that it ends in the 1, an ONE. Well, whenever you look at other medications representations that they gave us for this class, you can see that fluticasone, modisone, triamcinolone, they all end in the ONE. The other ending that's most common with corticosteroids is the "ide," budesonide, soclonesenide, flunesosolide. See, the ending of that name kind of tells me a lot about that medication. It tells me what class it kind of belongs to. So if I was to get a medicine on a test and I didn't know what it was because I'd never seen the name before, I'm going to look at the ending, the last name of that drug, because usually the last 3 letters of a drug will tell you where it's coming from. Okay, so remember that. Don't get thrown off. Remember your endings. An "ide" or an "one" is usually a corticosteroid, and we know how those react. They help to decrease tissue inflammation, decrease swelling. Another type of medication that we can give for a patient that's kind of preventing the body from having signs and symptoms of allergic reaction is something called the mast cell stabilizer. So the mast cells react, which sets the histamine off. So basically a mast cell stabilizer just kind of like says, time out. We're not going any farther than this. We're not even going to activate histamine. We're going to stop at the mast cell level, which is not going to allow the histamine to react. So this product actually came over the counter. Shocker! So you can buy it over the counter, sprayed up your nose, again, right in here. You'll also see this medication later when we talk about medications that are going to affect the lower respiratory tract. We can use this medication also in our asthmatic patients, which we'll talk more about later. Decongestants. Thank God for decongestants. So let's say you have a patient who's developing a snotty, runny nose, and they didn't get to their antihistamines in time, and now they're all swollen, and they come and they're like, please help me, I'm miserable. And their nose is all swollen. The good news is we have decongestants, because if we didn't have decongestants, this would be a pretty miserable time for anybody. So what the decongestants do is they actually work with our alpha adrenergic receptors, and they cause the tissue and the blood vessels in here to constrict up. We can give these one of two ways. We can give them orally or intranasal. If you had to ask me which one is my favorite, I would have to tell you that intranasal decongestants are my favorite, because I get to relax a little bit with my patients, because that medication is only going to affect right in here in the sinus cavities and the nose, okay? The reason I wanted to just start here is when we start taking these orally, then I'm going to get a systemic reaction all over this beautiful body. That can cause a real huge problem if my patient already has another disease process going on, like high blood pressure, coronary artery disease, or even COPD and asthma. So we've got to be careful with our decongestants. So with our decongestants, there's a couple of things you need to know. Number one, we cannot use these long term, okay? For like 3 to 5 days, and then that is it. If the patient uses them for more than 3 to 5 days, they can get rebound congestion. When they get this rebound congestion, what's going to happen is they're going to put that medicine up there, and their congestion and their mucus is going to get worse. And it's horrible, because the only way to get them out of that cycle is to physically drive them out. Like, it's like a drug addict. You're like, no more, no more. Okay, so typically rebound congestion, I caution them against very, very highly. If you have a patient who comes in, they're like, I just can't get over it, and you're looking at their medication list, and all of a sudden you see that bottle of Afrin there, you got to ask, how often are you using this? Because people can get addicted to it really, really fast. They really, really like it. I tend to tell my patients with the intranasal decongestants, I tend to tell them I want them to use these only at nighttime. And I'll tell you why after I tell you about oral decongestants. So with the oral decongestants, we have two different ones that we can purchase over the counter. One is pseudoephedrine, and the second one is phenethylamine. The great news about taking the medicine orally is that there's really not any rebound congestion to be worried about, so they can take them forever and be fine. However, pseudoephedrine is highly regulated by the DEA. In fact, if I want my patients to take pseudoephedrine, they actually have to go to the pharmacy counter, go to the pharmacist, present their license, and then they will administer it to them. But they're being tracked. The reason they're being tracked is because pseudoephedrine is the primary ingredient in methamphetamines production. So like in crystal meth, this is the primary drug that they use to make it. That's the reason why it's highly regulated. If they were to walk into the pharmacy and just pick a box up without checking with the pharmacist, that drug is phenethylamine. I will tell you that in my experience, I have about a 90-10 mix. I have about 90% of the patients will respond really, really well to pseudoephedrine, and 10% of them, but only 10% of them respond really, really well to phenethylamine. So if they're taking an oral decongestant and we're not getting anywhere, I look at the preparation that they're taking. and figure out which one it is because they just call it all Sudafed. And if it's phenylphalerin, I recommend the pseudoephedrine. If you're taking pseudoephedrine and it's not working, I recommend the phenylphalerin. Okay. My concern is when my patients take the Sudafed or the phenylphalerin is we get a rise in blood pressure. My patients who are cardiac patients cannot tolerate that. So I have to be very cautious with those. The other problem is with both pseudoephedrine and phenylphalerin, it is known to cause very vivid dreams and of nightmarish capacity. So they'll take the medication at nighttime and they can breathe, except they're not sleeping because they're chasing demons and running from clowns and having very unpleasant dreams. They get no rest if they take this medication at night. So generally what I tell my patients to do is take this one, the oral decongestant, during the morning, and then at nighttime before you go to bed, then use the nasal one. Okay, does that make sense? Then that way I can prevent pretty much the patients from developing rebound congestion problems because I'm spacing out the dosages, and then I don't have to worry about as many cardiac effects because we're going to take it during the daytime. Okay. The other thing you should know is that pseudoephedrine comes in different dosages, different durations of action. They have a 4-hour tablet and they have a 12-hour tablet. Okay, so just be watching out for that. Which one is your patient on to figure out how best to advise them to take their medicine. So when we have allergic rhinitis, sometimes we'll develop a cough. It can go down deep into our throat and just kind of irritate our cough center, and that just makes, again, miserable. So anytime we have these dry, tickling, non-productive coughs, I want those to stop because they're irritant to the throat and they're not being productive. If it's a productive cough, meaning that you can spit something out, dude, I do not want to suppress your cough. I want you to get that stuff out of your lungs, okay? But nobody, and I mean nobody, gets to cough at night. Coughing at night means that you're not resting. If you're not resting, you're not healing. So I tell everyone gets to cough during the day, but nobody gets to cough at night. We have a couple of different options on treating patients with coughs. We have the opioid treatment, a non-opioid treatment, expectorants, and mucolytics, and we'll go over each one of those. So the opioids, what they do is they actually help to dampen the cough reflex by affecting the CNS. Unfortunately, our opioids come with a lot of fun little side effects that go with them. Nausea, vomiting, constipation, confusion, dizziness. This is not fun stuff. So we really want to reserve our opioid cough medicines, our codeine and our hydrocodone preparations for those patients who are pretty severe. I also give these out very cautiously. As a provider, I want to make sure that I'm not handing a patient who has a drug problem a medication that they can have a drug problem with. Okay, so be cautious whenever you see these medicines come up on someone's list of meds that they're taking all the time. You should be asking yourself, why are we taking this and how long and when are we stopping? Again, a very brief, short period of time to take this medication. With opioid medications, one of the phrases that I want you to get into the habit of saving is, you shall not drink, drive, or operate heavy machinery when you take this medication. And this also goes for some of our, especially our first generation antihistamines. They're no joke, people. You drink, you drive, you operate heavy machinery, really cause a car accident or endanger your life or others. So we just don't chance it. The other medications that we give are antitussive, are non-opioid. I want to spend a little bit of time talking to you about our prototype here. The prototype on here is called dextromethorphan. This is an over-the-counter product, and typically it is mixed with something else. The reason you'll know it's mixed with something else is like if you were to go and stand at Walmart pharmacy and look for a cough medicine, when you're looking for the cough medicine, you're looking for the one that says something, it'll have the name, and then it'll say DM, okay? The DM stands for dextromethorphan. So the most frequent one that I can think about seeing is Robitussin DM. Well, what that one is, that's a combination product that is both guaifenesin and dextromethorphan. What's really interesting about dextromethorphan is that when it hits the body, it breaks down into almost the same chemical substance as codeine itself. So that means that we can get hallucinations, speech, dizziness, drowsiness, you name it. The exact same problem that we were having with the opioid medication, you can now get with dextromethorphan. The children have figured this out, by the way. This is quickly becoming one of the most frequent abused medications in the teenage population. And the reason being is because being good parents like we are, we keep these medications in our cabinets. Well, the kids figured out that if they drink it, that they can really get a little high. So for those of us who are moms or dads or caregivers of teenage children who obviously lose brain cells or something during that time period, you need to make sure that you're keeping a close eye on your dextromethorphan. Put it in your bathroom cabinet where the children can't sneak out and get it. It needs to be locked up. There is some legislation coming out that may actually be locking down dextromethorphan to where it would be a not a prescription, but you'd have to get it from the pharmacist. Again, we'll be swapping our a license in order to get that. My other favorite medication, I really like this one. It's called benzoate, also known as a Teflon Pearl. What's great about this one is that if I have a cough and it's that dry, irritating little cough that just won't go away, you can give this medication and it's non-sedating, so the person can continue to work. You do need to make sure that you instruct your patient when they take a Teflon Pearl, it literally looks like a little pearl, like it's little and it's small and it's yellow, but they put it in their mouth and then they drink a full glass of water with it. This medication technically goes down and it numbs the stretch receptors in the lungs so the patient doesn't cough as frequently. It does require a prescription. I think it's pretty interesting that benzoate, which is almost more benign, it is more benign than Robitussin, and benzoate requires a prescription. I think it's funny. No one's abusing the benzoate. If you get a benzoate tablet or Teflon Pearl, it's because you need it, and by golly, like I said, they're one of my favorite things for a cough to give to a patient because they work really, really well. So sometimes when our patients get these coughs, it's because they have all this extra mucus. Their parasympathetic nervous system is just producing all this stuff, and it's slimy, and it's thick, and it's very viscous, and these patients can't get it up, they can't get it out, it's just gross. So what we do with that is we give patients expectorant. The most common expectorant over the counter is known as guaifenesin. In fact, it's the only expectorant that I know of. So with this medication, it can cause some drowsiness. In my opinion, not as much drowsiness as dextromethorphan. It can cause a headache and GI upset. But for the most part, you can take guaifenesin and not really have any huge adverse effects. We want you to take guaifenesin. It works best if you take it with a full glass of water. So there was a study. And in this study, they took all these patients that had these thick bronchial secretions, and they took half of them and they gave them guaifenesin and said, hey, drink water. And then they took these other half of the patients, they gave them no guaifenesin, and they told them to drink X number of milliliters of water. In the end, both patients said they felt better. So not really sure if guaifenesin is all that it's cracked up to be. But here's what I tell my patients. If it works for you, let's stick with that, okay? So if you think guaifenesin is doing great, okay. If guaifenesin is not doing what you think it should be doing for yourself, then please, by all means, drink some more water and see what happens. We do have some populations of people that their secretions get so thick that you could paste wallpaper with them, okay? They're just nasty, and they're viscous, and they're slimy, and they can't get up, and they can't get down. We do have a product called mucolytics. The most famous one is known as acetylcysteine, see, I can say that, also known as Mucomist. And what this medication does is that it literally chops up the molecules that are making this so viscousy. It breaks them all apart so that those secretions now are much, much thinner, so the patient can get them up. When we're talking about bronchial secretions, you will actually put this in a nebulizer mask and aerosolize it, and the patient breathes it in. The problem is that when you give this medication, it doesn't matter if it's aerosolized, IV, PO, it smells like stinking rotten eggs. It is horrible, but it works great, okay? The other thing you should know about this medication is that if a person overdoses on Tylenol, we can actually give this medication IV, and it's the antidote for an acetaminophen overdose. There's one other medication on the market, the Dornase Alpha, known as pulmonzyme, and it helps to break down the DNA molecules for thick secretions. We tend to see Dornase more in patients who have like cystic fibrosis, the more those chronic issues, so they don't always go around smelling like a rotten egg. So the nursing process for giving a patient medications for cough, cold, congestion, allergic rhinitis, it always is the same thing, guys. Before I walk in to give that medication, I got to look at that patient's health history. What about that health history am I concerned about? If my patient has COPD, my patient has cardiac disease, my patient has epilepsy, I need to know those things before I give these medications, because these medications can affect that and make those problems worse. So past medical history, past surgical history. Is the patient pregnant? Are they breastfeeding? If they're pregnant, there's a lot of medication limitations because we know about drug classes, right? Breastfeeding, how is that milk going? How's that mom taking that medication going to affect her milk supply? Is it going to be able to give it to the baby? Does the baby really need a stimulant like a pseudoephedrine? I don't think so. With smoking, I need to know if they smoke, because again, if they're having a chronic cough, I need to know, like, are we dealing with a smoker's cough? Am I dealing with a pneumonia? Am I dealing with a cancer? Is this the beginning of COPD? Is this asthma? Understanding that smoking history can kind of help to guide me into what I may be looking for and thinking about this patient. Baseline vital signs. Are they hypertensive, hypotensive? Are they bradycardic, tachycardic? How fast are they breathing? What's their O2 sat? Before I do any of these interventions, I need to know those things. Labs. So which labs did I really look at here? For the most part, if I thought my patient had an illness that was causing them to be sick, I'd probably look at their white blood cell count. Don't really know of any others that we might could look at unless we got into some of those fun and funky, like immunological, allergic type reaction kind of labs. We want to make sure that once we give the medication or the patient takes something, that we're continuing this assessment. We want to know, did what we give actually work? We want to know, after we gave that medication, within 30 to 60 minutes, I want to reassess those vital signs. Are we still baseline? Did we go up? Did we go down? Is the patient having any adverse reactions? Are they puking their guts out? Are they, okay, what did that medicine do to them? Did we get the therapeutic effect that we thought we were going to get? And always thinking about safety. Safety, safety, safety. How often do I need to tell my patient, do not drink, do not drive, and do not operate heavy machinery when you take this medication? So a lot of times when our patients go to the pharmacy, they buy a lot of multi-med preparations. Dayquil, NyQuil, Advil, Global cold and sinus, Tylenol, cold and sinus, Tylenol, Theraflu, and then you flip over the box and it's just like this massive array of chemicals that someone just like, let's put all this together. It drives me insane. So sometimes I tell patients, I'm like, look, which one of those medicines worked for you? They're like, I don't know, I took them all. I'm like, well, okay, may not be the absolute best approach. So multi-med preparations can cause our patients problem because, one, we don't know what worked. If something goes wrong, we don't know which product it was that did them wrong. And then the third thing is that they may not recognize that this is a multi-medication product, and they could be taking additional medications on top of it. Probably the most notorious one that I think about is like these like Advil cold and sinus. Well, they think it's for their cold and their sinus, not recognizing that there's additional Advil or Tylenol in the preparation. And then they're like, yeah, I feel really bad, man. Next thing you know, they take more of the Advil or more of the Tylenol on top of the dose they already took. And then I'm like, oh my gosh, do I need to give you like an antidote? I'm worried about your kidneys. How's your liver feeling? It's bad for business. So I don't like multi-med preparations. They confuse me, they confuse the patients, and can really lead to some overdosages. So this is Jamie's prescription for cough and cold. What this is single dose products given in different times and different stages. And this would be for the adult treatment of a cough or a cold. So the first thing I always start with is fever, aches, and body, explaining to people like, look, when you don't feel good, you got to rest. If you're not resting, you're not going to get better from this. In fact, it'll take longer. So I recommend the Tylenol and the ibuprofen. I always try to do a lot of education with the ibuprofen because it has so many names. Motrin, Advil, ibuprofen. Okay, Tylenol the same way. Tylenol, acetaminophen, non-aspirin pain reliever. I mean, you're killing me here, Smalls. Pick a name. Pick a name. For my sinus congestion, again, I try to encourage them to do some non-pharmacological things before we do some pharmacological things. I use a lot of hot peppermints, hot steamy showers. We use our essential oils here, okay? Use that stuff to your advantage. If they're going to smother tea tree oil on it, let's use it to help treat our cough and cold. Here's my recommendation. Again, you see how I separate out the Sudafed and the Afrin. I don't like my patients taking pseudoephedrine at night. It gives them wild and crazy dreams. Well, I'm telling you, take a Sudafed and try to go to bed. All of a sudden, your mind is like, whoop, 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 whoop. The other thing that I absolutely love is my Neil sinus rinse, and I'm gonna go get mine. I'll be right back. Okay, I'm back. So I went and got my stuff because I wanted to show you what it looks like. All right, so this is called the Neil sinus rinse. It's also known as a neti pot. So what you do is you go to the store and you can get like whichever one that you want. I tend to recommend this one for the patients. Some people like the neti pot, that's fine too. What you do is you purchase that, and then you get these little packages, okay? Little package like this, and you take the package and you dump it all into the bottle, and then you fill the bottle up to the line with warm water. Then you have the patient go over the sink and they shove this in their nose, okay, not hard, just enough. And then when you push, the water shoots out like this and goes in through the sinus and out the other side. And if they're sick and got a little something going on, all of a sudden this green, massive, loogie, looks like Slimer from Ghostbusters comes out the other side. But you're not done yet, because they're going to do half of the bottle on one side and then half the bottle on the other side. And I literally want them to do this every morning and every night. This right here is actually the #1 recommendation for anyone who gets frequent sinus infections. I will tell you that I believe in this product so much that as a nurse, when cough, cold, and flu season hits, when I'm working in the emergency department and I've dealt around a whole bunch of hacky, loogie patients, I will go home at night as soon as my shift is over, or first thing in the morning, whenever my shift is over, and I will rinse my nose out. And that's how I have prevented myself from getting the flu. Knock on wood. Okay. I tell my patients to take Zyrtec. No, I don't have stock in the Zyrtec company. And I don't care if they take Zyrtec. I don't care if they take loratadine. I don't care if they take venlafaxine. I don't care. I want them to take some sort of an antihistamine every morning. Benadryl, we can take that one at nighttime. So a little fun fact about Benadryl is that not only will it dry them up, it'll also make them sleepy and it'll make them stop coughing. Okay, it's kind of having a little bit of an antitussive effect too. Then the other thing I like to do is I like to, when they have these symptoms all going on all over and they've got all this snot running out, is I like to punch them in the face with the good old-fashioned intranasal corticosteroid, and I'll have them kind of beef up on it for 3 days. So one spray in the morning, and then do it again at night, and we'll do that for 3 days, and then just every day to kind of like kick them into overdrive so they can feel better faster. My other recommendation is that I tell people, I'm like, look, salt water is medicinal. I need you to gargle with warm salt water. All that snot and everything is draining down the back of the cavity and it's grating the tissue off of the throat. Think about this. Remember that mucus has got enzymes in it. Those enzymes are meant to digest. So that's literally what's happening. Those mucus is full of enzymes and it's sliding down the back of the throat and it's like just scraping all the tissue off. So if we take the salt water and we gargle it, it helps to neutralize those enzymes and helps to get rid of them. And then plus bacteria don't like the way salt water tastes. They're out of there. I love Vicks Vapor Rub. Okay, I don't know if it's witch doctor medicine or what, but one time I had a cough and someone told me to put the Vicks Vapor Rub on my feet. Now I'm a believer because I stopped coughing. I don't know why. Okay, so I put it on my feet, I rub it on my chest, I'll shove it up my nose, well, not up my nose, but on my nose. So again, I'm a Vicks Vapor Rub believer. My grandma could not have been wrong. And then my other favorite trick is Johnson & Johnson Vapor Bath. It's in the baby section. It's usually in a green bottle, and it smells a lot like eucalyptus or peppermint. You take that, run a warm bath. The heat and the steam opens up all of your sinus cavities. All this green stuff starts coming out. You can breathe, and then you slip into bed and go right to sleep. All right, guys, I have stuffed you full of information all about allergic rhinitis and how to treat a cough and a cold. I hope you can apply this information to your practice this week. See you guys next time.